So in case people are filtering through, we'll just be chatting a bit while we're waiting.
Yes, we are gathering now. We have 47 people. Yeah.
Okay. Yeah, I can see the participant going up. So to anybody joining us, welcome. We're just going to be taking our time a bit for the next half minute or minute while people are joining. I can see a number of participants rapidly going up. It's good news for the EANS and for our speakers. So we're just going to give a bit of time to anybody joining. Welcome. Okay, so it looks like we've not got many more people so far joining. Obviously, people are going to be joining as we start, but I think in the interest of time, probably we can keep it prompt at starting at 4. So to those who've joined, participant, we've got 120 or so. It's a great number. Welcome all. Happy New Year, belatedly. And thank you to EANS for inviting me to chair this session. Thank you to Mansour, who's been organizing this, and all the hard work from everybody else in the EANS in the background. So this is the first teaching session of the year. I think these are fantastic, these virtual sessions. We've had a lot of them in general within the specialty. I think they're fantastic, and I think they're here to stay. And if there's any positive from what's happening in the world with COVID, then definitely this is one, if we can take any positive spin. And I think the CSF task force have been doing a great job. I've listened to some of their talks. I think they're very, very informative. And quite frankly, I'm probably as excited as many of the participants who are going up still. They're going 130 odd now to listen to this, because I think it's something that we can all learn from. So the topic of the day is IIH, and we've got 2 fantastic speakers. We have Susan Moran, who's a consultant ophthalmologist from Birmingham. She's a neuro-ophthalmologist interested in IIH and has been involved in developing the consensus guidelines. So there's a lot which I'm looking forward to learn from her. And she will be telling us about, I mean, we really depend on ophthalmologists for this as neurosurgeons. And, you know, we're part of a multidisciplinary team, clearly. And always you need good relationships with your ophthalmologist when treating IIH. So I mean, we're going to be interested to hear what to look out for, what the differential diagnosis is, what's the worrying things, or what does she look for on examination when we're thinking of how to prevent visual loss, etc. And probably an overview of some of the management options and the knowledge that she's gathered from treating a lot of patients. And there's a large volume of patients which she's been looking after in Birmingham. So I'm excited to hear that. And then after that, we'll be heading to Sol Rajak, who's a consultant oculoplastic surgeon in Brighton. Both speakers are keen researchers, and he will be talking about optic nerve fenestration and what his views are. Technical views, like, again, very interesting for neurosurgeons. We don't often see this, and how that treatment to him looks compared to other treatment modalities and how it fits in. I think all of that's going to be exciting. So to the participants, we've got over 150 now, no pressure speakers. I'm going to ask if you post your questions to the Q&A box, so not the chat section, the Q&A section. I'll be keeping an eye on that. I'll be doing my best to sort of summarize points and put it to our speakers, and I might interject as well if it helps and breaks the talk up to pose some of your questions to them. So without any further ado, if we can go to Susan to start us off with. Thank you so much, Susan.
Lovely. Thank you so much, Rafid, for that lovely introduction. I'll just start sharing my slides. And I am really happy for Rafid to let us know if there are any of our colleagues that want to ask a particular question. As per the introduction, I'm a consultant neuro-ophthalmologist at University Hospitals Birmingham. And as Rafid said, I work incredibly closely with our neurosurgical team. The head of our CSF is George Salumas, and you'll hear a lot in the sort of things we talk about from neurosurgery, but also from my colleague, Professor Sinclair, who's a translational clinical scientist. And we have written a lot over the last number of years around the experience, not only of our patients in Birmingham, but in the UK. And really this is to try and help streamline care for these patients, because it's a tricky disease. They present to lots of different specialists, and we have all fixed ideas about how we treat these patients. So the real learning objectives of what I'm going to talk about in 20 minutes, because we can't cover the whole of IIH, is really how do we protect the vision, because that's what my neurosurgery colleagues help us do. Obviously, there's a lot around managing the underlying cause, and also the morbidity of headache, which I'm going to touch on just very briefly. But really, it's about protecting vision today. So I thought I would step back and say, well, what is raised intracranial pressure? And as a group of experts here on this seminar, you are very well versed that raised ICP is a medical emergency, not only because it has some serious causes that could be potentially life-threatening, but for things like IIH, it's potentially sight-threatening. And IIH is a very curious condition that mainly affects about 90% of women who are overweight or with a larger body habitus. It's linked with disabling headaches, which drive reductions in quality of life. Patients present, they can often have low mood or other mental health issues within the disease. They can have visual loss. We think the underlying pathology is really a metabolic dysregulation. There is a cardiovascular risk, which is relatively unknown and a new finding in this disease. And our patients have this thing they describe as like a brain fog, cognitive functional changes. And some of the research that we're going to bring out this year is going to show how we're able to change the cognitive function with reducing intracranial pressure. And the patients are often can be fatigued. We have a real problem across the medical specialty here, because this disease is increasing with the worldwide explosion of obesity. And the good news for you guys on the call really is the majority of the disease is benign and will remain in Sol's clinic and my clinic in ophthalmology and neurology. And as neurologists and ophthalmologists, we've got a lot of work to do with this large group of patients and how to treat their headaches. But where the neurosurgery is going to come in is really about 7 to 10% of our patients are going to be in a bad way. They're at high risk of rapid visual loss. So I thought I'd go to a really quick case. We don't have a lot of time, but this is a typical case and brings out a few things. 19-year-old Caucasian woman out shopping, notices blurring of vision. She's had headaches. It started 8 weeks before. She's been seeing a doctor who's treating these, and she's having real good transient visual obscurations. That is a graying out, blacking out of vision, which is very transient, seconds, not normally minutes. These usually happen rapidly. Once somebody's starting raised intracranial pressure, they'll become more frequent and more terrifying, but they don't last for a long time. And she's starting to get the pulsatile tinnitus that a large proportion of our patients get. There's nothing really in our past medical history that we're going to worry about, but we've taken a good drug history to exclude sort of precipitants of raised intracranial pressure, such as vitamin A, isotretinoin. We've made sure she's not anemic because 10% of these patients can be, and you can treat the anemia and you get the same response as if you put in a shunt if you treat it quickly and appropriately. So back to our patient, the visual acuity in the right eye is excellent. So 20/20 vision, excellent color vision, but in the left eye, the vision isn't quite so good, but a red flag for me, color vision is down. When I check the pupils, she's got a left afferent papillary defect, and she's also starting to have some signs of a sixth nerve palsy. So this is somebody who is presenting with signs and symptoms of raised intracranial pressure. And this is her field. So on her left eye, she's starting to have severe problem with her visual field. Now, she was seen initially at another hospital, and these are her discs, and they don't really look like blood and thunder. And this is another little point to take home, is your discs can look like this and you can be losing vision. And there can be patients with lots of blood and thunder going on that are not losing vision. So you have to correlate structure with function. And so how are we going to manage this patient? Well, we've got a management plan that we're going to talk about, but how was she managed? Well, she has a CT scan, which is normal. She gets a lumbar puncture, which shows that the pressure is over 40. And she started on a very small dose of Diamox and gets sent home. Now, this is really inappropriate because she's losing vision, and we know she's losing vision. So the casualty card comes over to us here. We recall her that day. Her vision has deteriorated further. Now she's got loss of vision. This is the late bad sign of somebody really having issues with their vision. And this is somebody that needs surgical intervention. And these are her fields. It's getting much worse. And she goes upstairs under the care of our neurosurgeon and has a shunt placement. So the management principles for IIH in these acute patients that we get with rapidly declining vision is surgical. And we're going to talk a little bit about that. Now, in the eye clinic, we actually have good ways of looking at these patients. I think long is gone, looking at these patients with the direct ophthalmoscope, because in essence, we have really good tools that we're able to use. So everybody can check a vision and do color vision and look at the pupils, which is really important. We have fields, whether it be automated or static perimetry. And I'm going to touch on that in the next slide. We need a good dilated examination. We can't just look if the patient's not dilated. We need to see around the eye and make sure there's no other things going on that would lead to another differential diagnosis. And really importantly, what I absolutely love is optical coherence tomography. This is specialist imaging of the eye and the optic nerve that allows me to determine what is happening beat to beat in our patients. So I wanted to talk about Goldman visual fields, and one of the reasons I wanted to talk about it was this used to be our gold standard of how we would look at neuro-ophthalmic patients. And we're lucky at UHB we still have our machines, but obviously around many centres they no longer make them. So often our patients have Humphrey visual fields. And what I would say is they're not brilliant for the neuro-ophthalmic patient because they require cooperation and concentration. And I've already said our patients, not only do they have horrible headache, but they also have this cognitive fog, all right, which is related to the condition that they have. So performing these visual fields is actually quite tricky for them. But the difference between these and our Goldman is they don't scope the peripheral visual field. And IIH is a disease of the periphery. And it's very important that we think about the type of field that is being done in the patient to determine truly whether they have visual change or they don't. And this is just some of the grey scales showing the different types of patients I might get through in IIH. They can get anything particular. I mean, we see the big blind spot increasing, but really we've got to think about this as a disease of the peripheral in. And there's lots of literature, and I'm not going to really dwell on this because I know you're going to be able to go back and look at the presentation, but we have starting to get very good experience about visual fields. But we know in the IIH group, they need to perform the visual fields a number of times before we have a really good understanding of what actually we're able to interpret from the visual field. And often people will say to me, well, how do you know when's the point? Should they have surgery or surgical intervention? And this is tricky because the literature in this relatively rare disease is not big. So we take things from studies like the IIH treatment trial and look at differences in some of the parameters the visual field tells us. But for me, it's much more of a combination of what I'm seeing not only in the whole ophthalmic examination, but obviously the visual fields and the OCT structural changes that I see. So I could talk about OCT forever in every neuro-ophthalmic condition that I share with my neurosurgeons, but I thought I'd just put up some slides of the types of scans I do for my IIH patients. I always do a circle scan called a retinal nerve fiber layer. I always do a disc volume because it gives me beautiful sections through the optic nerve head. And then I do something called a posterior pole scan, where I look at the ganglion cell analysis. And that starts to show me early signs of damage, as if something has been going on for a long time, or whether there's fluid tracking from the optic nerve towards the macula. And I'm going to just run through a little bit of these slides fairly quickly in the interest of time. But the retinal nerve fiber layer, when you read the literature, is the most commonly reported feature because it was the most original that was originally seen. But there is a floor effect. And when we read about the floor effect, this more relates to other optic neuropathies, such as glaucoma. And what I would suggest is, even when your patients get to the floor, it's very important with people with raised intracranial pressure not to stop monitoring them. And we've shown a nice little case series of patients where they've been on the floor of the retinal nerve fiber layer, and when they get a shunt blockage or reoccurrence of their IIH, we can clearly see the retinal nerve fibers swelling again. And in some cases, this is not discernible on direct ophthalmoscopy or looking at the slit lamp. So it's really important that we have this technology, that we're able to use it. In our IIH clinic, we love this utility of cross-sectional imaging of the optic nerve. And you can imagine being able to show a patient that is working hard to lose weight in this condition, how important it is to show how much progress they've made, because it's really difficult to describe what's going on. So our patients really love this kind of, you know, you've lost this amount of volume of your optic nerve, and it usually correlates nicely with their reduction in their weight. But the cross-sectional imaging also shows us what the red arrow is showing is things underneath the optic nerve. This is called a FOMS, another lecture. But these are things that don't necessarily mean the nerve is still swollen, but is elevated because of things underneath the retinal nerve fiber layer. So we show improvement in papilledema, but also sometimes we show this reoccurrence. And this is one of our patients that reoccurred. There's some beautiful literature coming out of Queen Square, which looks at spontaneous venous pulsations, and this is using the Spectralis OCT. It is an infrared video, a 10-second video, and this clearly shows spontaneous venous pulsation. And this is really helpful because they've been able to equate it to a level of intracranial pressure. And I find it's also helpful, even if I don't see SVPs on the slit lamp, this is a slowed down video. I look at my video and then I go back and look at the patient. And it's particularly important in those patients that we have with optic atrophy who don't have an intracranial monitor in, and we're trying to work out whether the pressure is raised or not without doing a lumbar puncture. We've recently published OCT imaging as a surrogate marker for intracranial pressure, and I post it here just as an aid memoir for you to go and have a look, because it's a really nice paper because it uses the Roy medical monitor with sitting telemetric ICP monitoring, and we were able to predict treatment effect at 12 months and 6 months or 24 months, looking at the central thickness of the volume scan. So we're starting to build up this beautiful picture that OCT imaging is really helping us define not only what's happening at the optic nerve, but also what's happening with intracranial pressure. So I'll just run through those slides because it's all in the paper. I think one of the questions is, well, who does require sight-saving surgery? About 7% of our patients in the UK will require sight-saving surgery. And I'm going to say, let's not talk about lockdown and the COVID pandemic, because we've recently published our data from last year where there was significant compromise of our new patients and our existing patients, and our shunt rate was very much higher than we previously had the year before. But it's really for those patients that have a functional compromise of their visual function. And I always say to myself when I'm looking at a patient, is there time for emergency weight management intervention? And we work very closely with our weight management experts and our endocrine colleagues. And in some cases, we've managed to turn people around in 7 to 10 days with extreme low-calorie diets. This is not a means for long-term weight management, but sometimes means we can escape having a shunt. When we know we've got that patient, and it may be patient declining vision, and I know within the guidance we said within 4 weeks, in all honesty, we see a lot of recurrent patients, particularly last year following lockdown, and I'm sure this definition will change of fulminant disease. If we're not able to do the surgery within 24 hours and we know that the vision is decreasing, we do recommend a lumbar drain be put in. We know this is contentious in the neurosurgical literature because these patients nearly inevitably have slit-like ventricles, and this can make a VP shunt more difficult, but it is something that hopefully in seminars later on in the year we will be able to show you some beautiful ICP monitoring of one of our patients with a lumbar drain in and a clamp of a lumbar drain to show what happens with the intracranial pressure. And because the literature, there is no good, high-powered randomized controlled trial looking at shunts, stents and optic nerve sheath fenestration, really we recommended CSF diversion or optic nerve sheath fenestration. So what happens around the world? Well, the type of surgery that you choose depends on your local expertise. With Saul's expertise, I'm sure the team down there really lean on him to do these beautiful optic nerve sheath fenestrations. But actually, sadly, there's only a few centres in the UK that perform this. Around Europe, it's variable from country to country. And there was a nice paper out in the US recently that really 1 in 10 people that end up with surgery for IIH have an optic nerve sheath fenestration. I think as doctors that are interested in this condition, we do have a responsibility to try and work out which surgery is more beneficial, not only for sight, but for also complications. I think surgical trials are very difficult to power and to recruit to. And in fact, the surgery trial in America closed because of lack of recruitment. So this is a tricky area. So we need to get the best level of evidence that we can. So I'm just coming to the last few slides. What are my red flags for somebody that might need surgery? It is somebody who has clear transient visual obscurations that are increasing pulsatile tinnitus also. The signs we talked about, reduced color vision, worries me a lot. Obviously, if it's asymmetric, and a fair few are asymmetric, you'll have a relative afferent pupillary defect. If it's bilateral, you won't. The Humphrey visual field is probably a later sign than a more peripheral Goldman visual field. Now, I've not mentioned headache, and this is my caution. Surgical procedures for refractory headache should not be done unless you really believe that you're going to be able to manage the headache. Because I would ask, is it truly medically refractory? We've recently published a really nice paper giving IIH patients with refractory headache a monoclonal antibody CGRP therapy, and it was exquisitely sensitive in reducing headache. So I would ask you to make friends with your neurologists, get these patients onto higher end headache treatments and see if we can avoid surgery. Surgical revisions for block shunts, again, I would urge you all to say, is there clear evidence of raised ICP and no other way of modification? And so shunting and stenting for headache in IIH is something we are not keen on, because surgery and intravascular surgery has complications, and sometimes the medical route, although it's a long route, can get patients back to normality. So we've got some nice sort of algorithms out there, and most of the guidance is all open access. So I would encourage you all to have a look at those, and we'd be really happy to take any questions.
Thank you so much, Susan. That's an excellent talk, and I think very helpful. But if, bearing in mind that we are mostly neurosurgeons who don't share your level of expertise in looking at the eyes, what would you, I think any other thing to bear in mind, that we're going to have people out there who are participants who have, better access to ophthalmology and perhaps less as well. Let's say we're, a standalone neurosurgeon, a colleague in Europe perhaps, who doesn't have access to ophthalmology. What would you advise them to be looking for? Clearly, some of the tests are not within the neurosurgeon's remit. would you be able to summarize what he or she were to look for, and what would, you mentioned some of them in the red flags, but could you summarize again what you?
Yeah, I will. So it does really depend whether this is a new onset patient or somebody that's had IIH for a number of years or recurrent. So if we take a new onset patient, I think the headache history there is key, because usually they don't have the historical raised intracranial pressure headache in the most. But for some people, they'll have started off with an episodic headache that grows over 6 to 8 weeks. And at some point, they'll start to get the pulsatile tinnitus within that. And then they will typically start to get visual obscurations. Those within that capsule, that's the history I'd be looking for. Why I take headache out of it is a lot of our patients turn up to casualties and other places with exacerbation of headache. And a lot of the majority of our IH patients have a migraine-like headache, and it's indistinguishable, the raised pressure from the migraine. And it makes it really tricky as a doctor to go based just on the history. And then to throw in the mix, our migraine patients can get pulsatile tinnitus in a quarter. Our migraine patients in a quarter can improve their headaches on a lumbar puncture. So all these things throw into the mix that makes it really difficult for doctors to depict out who are the patients that are going to run into a problem. So I think it is difficult as a standalone neurosurgeon. And, you know, we said before that, you know, we need to get friends in ophthalmology and friends in neurology where possible, because the OCT imaging is just revolutionized our practice and our ability to be able to pick out those that are pseudo-papilledema versus those that are true papilledema, even if you can't see at the slit lamp or with the direct.
So pretty much you'll be using OCT at diagnosis and follow-up. So it's key in both aspects, and how urgently you ask your neurosurgeon to intervene on an urgent basis, or indeed if we are thinking of optic nerve decompression. But that's your go-to. Is that fair?
Without a doubt, nobody passes go. It's a bit like going to an A&E and getting a CT head. This is literally ophthalmology department. The OCT is just such a fantastic modality.
Fair enough. I think that's all very helpful, and I think it's great that you touched on all the different management options, which does make this a tricky area. And you know, the paper that you've mentioned, I think would be helpful for all participants. I think it is a nice kind of consensus questionnaire, isn't it, in the JNNP, where it gives an idea of, according to which symptom, where the evidence lies in terms of management. And there are a number of questions brewing, but what I would think is, this is opened up probably nicely for us to go to Sol. Actually, I might go, before I jump to Sol, I might kind of ask you a couple of the questions on there, because there's a question about fields, and one question is to talk through the benefits of Goldman versus Humphreys. I mean, I do pituitary surgery, and you know, our go-to as a standard practice before I started was Goldman's. I find Humphreys easier in a way that you just look at it and you see the dark spots. Okay, there's the problem. But Goldman's, I mean, as far as I understand it, is more sensitive, etc. I would be grateful if you could run through a bit why you feel that way, and how it's specifically in IIH you would recommend it.
So I've got a bunch of colleagues I work with, and we're all on, you know, a various line of just all Humphrey visual fields. I'm in the middle. I do a bit of Humphrey, a bit of Goldman, and then other colleagues that just do Goldman. I would say you need a really good technician doing a Goldman that understands vision and doing the test, because if you don't have a technician that gives the patient time and understands how to interpret what the patient is indicating, you can get a lot of mess within your Goldmans and a bit of artifact. The reason we choose Goldman, or why one should choose a wide field visual field, so not necessarily a Goldman, you could have a wider field Humphrey, say a 30-2, or some of the Octopus, or there's many different types of field machines, is it's because the disease tends to affect the peripheral visual field before the central visual field. The central visual field changes usually happen because of fluid tracking from the optic nerve to the macula. So it's more of a physical change within the retina, whereas actually the disease where the, you know, effectively the CSF is compromising the optic nerve, is you actually see peripheral visual field change. So that's why you want a widest field as possible, But it's tricky because the automated ones are quicker to do. Any technician of quite a lower grade can do them. So it's this balance. We do a lot of Humphrey and IIH because we do a lot of clinical trials, and you cannot compare Goldman's particularly well in clinical trials. So
fair enough. Quite clear to us. Thank you. So one other question, there's a few questions about LPs and their role. Would you be able to just touch on that, as in where the role is in diagnosis and thereafter, basically?
Yeah, absolutely. So lumbar puncture for me is an absolute essential diagnostic criteria for the disease. I've recently been looking at some papers from a Canadian group, and only half of their patients do they use the lumbar puncture in diagnosis. I think it's at the start of the disease, it's very important to confirm this is actually IIH. A lot of our patients, there's so many papers out there looking at misdiagnosis in IIH, where people have funny looking optic nerves and headaches, because headaches, you know, ubiquitous. So I think we've got to confirm the disease. There is the importance of taking off some fluid as well and making sure that the contents are normal, and that's very rare that you would get an abnormality there. So for diagnosis, absolutely certain. During the disease, I'm not a fan of something invasive. I know my optic nerve imaging helps me a lot of an indication of where the intracranial pressure is. It doesn't make me choose a modality over another one. The only thing I would say about the defining thing about lumbar puncture opening pressure is, in my clinical experience, if initially it's really high, 76 or something like that, I'm thinking it's a drug cause. So I often get that sort of inkling that if it's really high, I'm looking for isotretinoin or vitamin A or a fluoroquinolone or something like that. And that's the only differential I would make, because if your pressure's 35, you can still have sight-threatening disease over if your pressure's 50. It doesn't discern how bad your disease is affecting your eyes.
So in summary, you depend on the OCT for that side of things, but for a diagnosis and after imaging, then that's the go-to for that. There is a question, I mean, just because it's about OCT, and before I think the last question before we go to Sol is, there's a question about the role of OCT and being more widely implemented across the UK. I think that might be specific to the UK, although we have a European audience, but it might be interesting for our European colleagues as well. What are the barriers, and does the measurements of RFNL in OCT help with characterizing visual field deficits in cellular lesions? So we've probably gone a bit off piece, but if you can summarize an answer to that.
Yeah, no, so this is a great question. I mean, we're lucky in the UK. We have a national health service system, but these platforms are quite expensive. So my platform I use is somewhere about 100,000 UK pounds. It depends on what platform you have. There's lots of different vendors. You can get sort of more affordable OCTs that will provide you exactly the same information as far as some of the parameters that we scan for. So we're very lucky. My American colleagues have to justify every single image that they take for their reimbursement. And so they have to choose which scans and when they do it. So I do totally recognize that I have a luxury to be able to do this on all my patients at every visit, and many different types of imaging. And we've not even touched on angiography and other things. The other thing is the person asking this question is very astute, because there's some lovely literature looking at pituitary compromise of the chiasm and retinal nerve fiber layer. But I would even take it a step further and say some of the ganglion cell analysis is a beautiful replication of what's going on at the chiasm, and correlates really well with Goldman visual field, visual field deficit. So absolutely, I mean, pituitary and OCT is another talk altogether, and also a totally exciting one with regard some prediction of you know, how the surgery results might be in resolution of vision.
Well, that's interesting, actually, because yeah, again, and my interest is in pituitary surgery, again, going off piece as well. But that would be interesting because you do get some of them reaching the chiasm, but no visual field deficit, etc. So those are the ones which may be useful to know. But again, in summary, thank you so much. I think that's an excellent talk. It's given us all an idea as neurosurgeons and what you're looking for, what's important, what the red flags are, what the different modalities are, and it opens it up nicely for our next fantastic speaker, Sol Rajak, and I think we all hear about it in neurosurgery, optic nerve fenestration. Some of us would be lucky enough to see it, or maybe not. So I think this is a chance for us to see what you do, what your results are. And I know you are a fan of operative videos, and I think everybody will be excited to hear what you have to say. So thank you so much.
Thank you. Thanks, Rafid. Thanks, Mansour. Thanks to the EANS office for organising it, and a pleasure to sort of virtually meet you all. It's an intimidating experience facing 180 odd neurosurgeons. We never used to be able to find one for love nor money, and now I've got 180 of them. But anyway, that's a separate story. I'm going to talk a little bit about, well, mainly about surgical decompression of the optic nerve, predominantly about optic nerve sheath fenestration, which follows on from Susan's talk. And it's also a good opportunity for me to talk a little bit about decompression of the optic nerve in the canal, which is a really interesting area. So hopefully that has moved on. A bit of brief anatomy first. So as you all know, 4 sections of the optic nerve going from the eye to the brain. Small section in the eye, then the longest section in the orbit. So that's mine and Susan's territory, the 2 of us, and the other 180 of you can look after the next 2 bits, intracanalicula and intracranial. We'll go through those bits in a bit more detail. So these 2 bits are the bits that we're going to focus on during this talk, but we'll go through all of them. This is the intraocular portion. This is what thousands of ophthalmologists look at every day. It's 1 millimeter of optic nerve, and I don't think there's much more to be said about it. The intraorbital portion is my bit as an oculoplastic and orbital surgeon. So it's approximately 25 millimeters long. It has myelinated fibers distal to the lamina cribrosa. So the lamina cribrosa is the sort of plate at the back of the eye, and then it starts to get laminated. So it starts to get myelinated, and so it gets much wider in the orbit. And it has all 3 meningeal layers on it. So as you know, it really is just an outpouching of the brain, and it has CSF, and it has this almost bulbous appearance to it because of having CSF and the 3 meningeal layers. And then there's the intracanalicular portion, which you'll see on the scans to the right. This one's actually one with trauma, but the left side is normal, and it's pretty small. You can see on the lateral side, it's hardly there at all, but the medial side, there's a bit more of a wall. It's probably the most vulnerable part because of being in this narrow bony canal. It's in the lesser wing of sphenoid. So you can see it in the bone at the bottom over here, the optic canal. It has an entrance called the optic foramen, and it has walls which you can access either from a neurosurgical or an endonasal approach, so a medial, a lateral, and a roof. And it's about a 6 millimeter circumference, and as I said before, it varies in length, but less than a centimeter long. And the actual canal and the nerve within it can enlarge with some pathologies. The intracranial part, I wouldn't pretend to tell a virtual room full of neurosurgeons what it is, but it's 10 millimeters long, and I'll leave it to you guys to look after. So surgical interventions on the optic nerve. So optic nerve sheath fenestration, CSF diversion procedures, which Susan mentioned, transverse venous sinus stenting, bariatric surgery, which Susan also mentioned, and optic canal decompression with or without fenestrating the optic nerve sheath. I'm only going to talk about a couple of those. So optic nerve sheath fenestration, so this is a schematic diagram of the optic nerve, and the aim is, from the French for a window, is to create a window in the optic nerve to allow fluid to leak out of the nerve. The history of it. So 1872, De Wecker, who you'll know from various surgical instruments, describes an inferolateral peritomy. So inferolateral in the eye, peritomy means just taking off the conjunctiva. So you need to picture yourself now at the front of the eye, and you've released a little bit of conjunctiva, a little bit of the white of the eye. And then he takes a big leap. He blindly places a neurotome, so a sharp instrument, behind the eye. So we've gone quite a long way back, and he incises the sheath, which is punchy, to say the least. And that's without anesthetic. And a neurotome is described as a long, 2-edged scalpel, which is used in dissecting nerves. So you've gone from the front of the eye to the optic nerve without anesthetic, with a very, very sharp tool. It gets slightly refined in 1889 and 1916 by going from a lateral approach, so from the outer side of the eyeball to the optic nerve, which is still how it's approached in some centres, and a fairly, perfectly reasonable way of approaching it. And then it falls out of favour, probably until 1937, when Dandy, who you all know from various syndromes and other neurological descriptions, starts to devise formal criteria for IIH. But probably the reason it falls out of favour is the lack of anaesthetic, because when you try and find the instruments, I think this top instrument was used, which is an enucleation spoon, so it's designed for removing eyes, but I think the sharp bits were used as a neurotome to pierce the optic nerve. And this instrument, this is apparently a veterinary instrument, but was also used for optic nerve sheath fenestration. And I'm not sure it was particularly well tolerated. 1964, Heyra, who you'll all know, demonstrates the effect of optic nerve sheath fenestration in monkeys, and it then becomes established as a technique for treating. And the next 50 years, as always with our modern medicine, we don't really do very much. We just refine the approach and get more specialized at it. And so the lateral approach got refined, then people started to approach medially, which is what I tend to approach. And more recently, one group in America, and actually it's got a lot to be said for it, go for a supromedial eyelid approach, because you don't have to take off any of the extraocular muscles in order to access the optic nerve. So what is a fenestration and why do we do it? So there's a lot of debate about whether we should just be making a slit or a window. So should we be actually removing a small section of the optic nerve sheath, or should we just be cutting a hole in it? And that depends on what the presumed pathophysiology of the process is. Are we actually creating a genuine window with continuous egress, continuous outlet of CSF into the subarachnoid space? Or are we creating an area of fibrosis that protects the optic nerve in that area just anterior to the fenestration? So it gives it a kind of buffer, a ring of scarring. It's all theoretical to some extent, although egress of CSF has been seen on scans, and it has been confirmed by one of the complications you occasionally get, which is a large bleb of fluid forming around the area that you've incised, which does suggest that fluid continues to leak in some cases, but not in all cases. And when you look again, quite often there is no evidence of fluid 6 months or a year later, despite there being good evidence that the procedure has worked. So it remains a bit unclear, and I would guess Susan probably is more qualified than me to talk about the more likely mechanism of action. So imaging, as I said, the early MRIs will show fluid leaking out into the fluid consistent with CSF leaking into the orbit, but later ones, you don't seem to see fluid. Then the question has arisen as to whether to biopsy or not to biopsy. It's not a question I had thought about until I started reading up about the topic a bit more. I'd never considered that when I would do a fenestration, I would biopsy the tissue, but actually there's a lot to be said for it. So anything you take out, you can send for histopathology, even a 2 millimeter square of optic nerve. And there are a large number, I've not encountered any yet, but there's a large number of anecdotal diagnoses of unexpected pathologies, which fits very nicely with Susan's comment earlier, that you really do need to be sure what you're dealing with at the beginning. And unexpectedly on biopsy, people have encountered meningiomas, lymphomas, metastases, and fungal disease. So I probably will change my practice now, that if I'm going to take out this window, why on earth not send it to a pathologist to have a quick look. The outcomes of optic nerve sheath fenestration. So there's some lovely studies. Sorry, I haven't got the reference out that I can give that to you. So 525 eyes put together, so this is a meta-analysis put together, and apparently 95% improvement in disc swelling. Now that doesn't, as we know now, always correlate with a visual improvement. 2/3 improvement in visual fields and similar in visual acuity. A small proportion, about 1 in 8, will worsen again, having had an initial improvement. And as exactly correlating with what Susan said, is that it is not a brilliant predictor as to whether the headache is going to get better because of the multifactorial nature of headache. Given that it doesn't always work, can you repeat it? Well, you have to be, you have to be quite confident to go straight back in again. But about 1/3 will probably have some degree of failure. There's very little data on repeat fenestration. But one small paper said 5 of 7 eyes improved, so that's good rates. And even more impressively, these guys then went on to do a tertiary and they got better results with the 207, or they've got to wonder whether by this stage those remaining 2 patients had had enough and just said, thanks very much, I think it's improved, after their 3rd assault on their optic nerve. It's a pretty low risk procedure, strangely, and once you know how to do it. It's actually not nearly as difficult as I'll show you as you might think. But it does, as with all procedures, have complications. So all approaches, you can damage the optic nerve. You can even, unfortunately, have a perfectly normal procedure where you fenestrate it and you lose vision anyway, probably because of damage to the vascular supply to the optic nerve. You can get a cyst forming. You take off the muscles almost, or with most approaches, so you can cause diplopia even if you put the muscles back on very neatly and tidily. You can do damage to the cornea, etc. I won't read them all out. A lateral approach, you are going past the ciliary ganglion, so that can be affected and therefore affect their pupil function. Medial approach, which is my favorite approach, you can cause diplopia, as we mentioned before, from the muscles. Supromedial, which doesn't take off any of the muscles, if you are confident, and it is a slightly tricky access, but it's, as I say, a good access, then really you're probably only at risk of doing damage to the eyelid itself by going through the eyelid, which generally recovers. So let's just show you a video of it. Sorry that the resolution's lost a bit in multiple changes to get it into a PowerPoint, but hopefully I'll be able to talk you through the procedure and you'll be able to see enough. So this is the peritomy. So just to take you back to that history slide, at this stage, they've made this cut and then someone just shoves a very, very long, sharp instrument around the back of the eye and feels the optic nerve, which I think is staggering, but impressive. So this is just taking away the conjunctiva. This is a squint hook going underneath the muscle. And again, apologies for the lack of resolution. So this is a squint hook going underneath the medial rectus. The medial rectus will then be disinserted, so removed from the eye, which is very standard for ophthalmologists. This is typical for all squint surgery. So we put a couple of stitches in it so that we know where it is and we don't lose it. So that's the stitches going, and this is still, at this stage, this is identical to squint surgery. So you'll see the stitch coming in here. Then we can transect the muscle away from the globe, and that will give us our access. So that's the muscle coming off. And if anyone does want a better video of it, please do get in touch. I can point you to a link on our teaching website that has it. This is a traction suture, so you can, this is quite a thickened bit of the eyeball where the muscle inserted, so you can put some quite robust 4-row silk in to get a good hold of the eyeball, and you need that good hold because you really do need to manipulate it. This is a lovely instrument which someone taught me when I learned to do this procedure. This is I'll just pause it. This is a tracheas, a pediatric tracheal dilator for dilating stenosed tracheas in neonates. And it works really well for sticking down the medial side of an eyeball. And it's got 3 prongs, and then you press the thing and it just widens up, and this space just comes beautifully into view, which if it wasn't for the low resolution, you basically almost see the optic nerve at this stage. There's a bit of fat in the way. So, but you've got this lovely view. It's pretty much self-retaining, this instrument. And then you start fiddling around with some cotton buds. I've used your roton dissectors as well to fiddle in there, which is very nice. And before long, this is another squint hook. Before long, you really do get this beautiful view of the optic nerve. So you can actually get there in minutes, actually. So you've got the optic nerve in view, which you, on the higher resolution, again, apologies for that, you can see very clearly. And then this is this sharp instrument. This is an exquisitely sharp instrument. It's used for making the incision in cataract surgery, but it's got a lovely curve on it. It's called a keratome, which is just, a keratome means a corneal incision blade. It's got this lovely bend on it, so you can stick it straight down that gap. And I'll just rewind that because that's the money shot. You can actually see, even with the low resolution, a sort of gush of fluid coming out there, and it suddenly looks rather wet. So that's your slit made, and some people would stop here. For no really particularly scientific reason other than once you're there, it seems right to actually fenestrate. This is something called a Kelly punch. It's used in glaucoma surgery, and it just punches a small window of tissue out of the optic nerve. And you can see the tissue there. I will just go back. You can just see the tissue there resting on the globe. I'll try and pause at the right moment. Oh no, sorry. Well, we'll try one more time. I'll try and pause it at the right moment. So this is the size, and it's about a 2 millimeter. There it is. Oh, sorry, that wasn't very effective. But in fact, we've seen enough. You then pull the muscles back on. So that's the reinsertion of the muscle. You can see the medial rectus being pulled back home again. So it's lifted steadily up, and you repair the conjunctiva. So that is an optic nerve sheath fenestration. It can be an extremely elegant, quick procedure that can take 20 minutes. It can be a sweaty misery that can take a long time fiddling around in orbital fat, like all surgical procedures. So that's really all I had to say on optic nerve sheath fenestration, but it gives me the opportunity to talk a bit about optic canal decompression, which I wouldn't recommend using for IIH because it's a more invasive procedure than you need to do, and there's no evidence that it works any better than optic nerve sheath fenestration. But it is an interesting area, and there's been a big paradigm shift really because of the advances in endoscopic endonasal surgery, that we can now access the optic canal relatively easily through an endonasal approach. And I guess a similar paradigm shift to pituitary surgery, although this is a much less common indication. So the sorts of things, I mean, I am speaking not from a position of authority on this. I'm not sure how many people in the world are in a position of authority, but having done 2 cases, I can't confidently tell you that that I am a great guru on it. But we do have the privilege, because I do a lot of endoscopic thyroid surgery, of seeing the sphenoid sinus and looking at the optic nerve and decompressing the orbital apex regularly, probably every week or 2 at the moment, and knowing that actually it's not a particularly challenging thing to go a bit further back to the optic canal in the sphenoid sinus. So the sorts of conditions where this might arise: fibrous dysplasia and McCune-Albright syndrome, benign tumors where you do not, for one reason or another, are not going to be trying to debulk the tumor, and you may just want to decompress the pressure on the optic nerve, which typically is focused on the canal, and trauma, very, very debatable, as you'll no doubt be aware, and we'll just cover that now. So optic canal decompression and trauma. So the headline, and probably the answer to the question, we'll go to the answer before the evidence. An AAO, so American Academy of Ophthalmology review in 2020 essentially said there is no substantial evidence to support decompression of the optic canal in trauma. And this is controversial because it is widely done. The reason they came to that conclusion is there was a big trial some years ago that many of you will be aware of steroids for post-trauma. And there was no benefit from steroids on the visual acuity outcomes. But there's a rather lovely paper with a large number of patients. I can't remember, I think it's 260 or something patients. I don't know how they found 260 canal traumas to decompress, but and that showed that 55% of patients improved with steroids and surgery, their vision. And you think, okay, this is pretty good. But 51% of patients improved with just steroids. And of course, there's no control group. And yet, if we go to the initial RCT, we've shown already that steroids probably have no benefit. So one does have to wonder, with a control group with no treatment, whether you might get an improvement of somewhere between around 50 and 55%. And that is the big problem with the research in this field. Other work, very, very small studies looking at erythropoietin, levodopa and carbidopa in a hope of protecting the optic nerve, but not substantial evidence. I'll give you my 2 cents worth for what it's worth. This is totally unevidence-based. My personal view is that the evidence does not support it, but, and this is my experience from thyroid eye disease, it is extraordinary that you can have really severe chronic pressure on the optic nerve at the apex of the orbit, for weeks and sometimes months on end, with significant visual loss of color vision, and decompress it, and it can recover, and sometimes completely recover. So I don't think all is lost. And my view is that if there is chronic pressure from a discernible bone fragment in the canal, there may be some merit in decompressing that, because that bone fragment may continue to put pressure on. But I don't think if you can see a discernible bone fragment, that taking off the wall of the canal is likely to help in what is probably traumatically permanently damaged at the actual instant, at the actual moment of trauma. Anatomical considerations when you're doing an endoscopic canal decompression. Obviously, we're looking at this area here on the medial wall of the optic nerve. So we can only access the medial and inframedial wall of the canal. We depend on you guys to access the roof of the canal and the lateral wall. The ophthalmic artery needs to be borne in mind. This picture shows it where it typically is on the lateral side, so not so much of a concern for us, but very occasionally it's found medially. So that would be a significant bleed. And it is controversial whether you should open the optic nerve sheath when you're there. My view is you should not, unless you're fenestrating for IIH, and this is not the right place to be fenestrating. So this is the intraoperative view. So, and I'll show you a video of this in a minute. But you can see the optic nerve over here. You can see the recess over here, lovely view of that hollow and the carotid artery beneath. And you can see this lovely curve of the carotid artery with the optic canal above. So it's tiger territory, but they are very discernible prominences in the sphenoid sinus, in the lateral wall of the sphenoid sinus. Here's another slightly low resolution video. And again, this is on our teaching website if people want to see it in higher resolution. So this is a microdebrider. Those of you who do endoscopic surgery will be familiar with this, taking us through to the sphenoid sinus. Lateral walls on the right. So this is the orbit that I'm waving the mouse around. This is just burring down with a diamond tipped burr at the orbital apex on the lesser wing of sphenoid. And there you can see the optic canal coming away from the orbit, going posteriorly. And you're really home and dry. And you can start picking off the wall once you've burred it down. You do typically, need to burr down a bit to be able to, and you need to do it in short, sharp bursts, because I would assume the heat and the vibrations of the drill are not good for the optic nerve. And there you can see bone fragments being lifted off the optic nerve. And you can do the whole of that 4 to 10 millimeter section in the canal relatively comfortably. So what can go wrong? You guys are very familiar with operating around the carotid. We are certainly not as ophthalmologists. I don't know how many, some of you may have done PJ Wormold, who's an ENT surgeon in Adelaide, Australia. Some of you may have done his carotid injuries course. I cannot recommend it enough. It is the most extraordinary course. It's mainly attended by skull-based surgeons, ENT and neurosurgeons. But this is on the course, so don't worry, I haven't yet hit a carotid. This is a bit of plastic piping over the carotid artery of a sheep under general anesthetic. And so those of you who've done the course will be familiar with this slightly terrifying experience. So you burr down, you can see the pulsation, you burr down the plastic piping, you lift it off as if you're lifting, it really does feel like lifting off bone fragments. Obviously we prefer to lift them off the optic nerves and the carotid. And there it is. And then you do something that is just so uncomfortable for a surgeon, which is you start to plot how you're going to injure this optic nerve and keep your sheep alive. So this is a clamp of the optic nerve. So there's a bit more bone. So clamping the optic nerve. And then you make an incision. Sorry, not the optic nerve, the carotid artery. And then you make an incision in it. And then you do something utterly terrifying, which is you release the carotid. And you then learn and then practice fixing a carotid, which is, with the right technique, doable, at least on the course. I've not had to do this in real surgery yet, but it is an extraordinary course and an extraordinary experience, and does give you a degree of confidence, at least endoscopically. So you get control of the bleeding with the sucker, and you put a muscle patch on, which was their great sort of discovery. I'm sure it's been discovered before, that a muscle patch actually can stem the bleeding very quickly and form a permanent bond over an arterial breach. So that's all I have to say. A couple of shots of Brighton. So please do, they'll be very familiar to Mansour and Rafid. The two piers of Brighton, one in a ruined state, but rather gothically beautiful, and the other just a trashy pier with amusement arcades, but quite pretty in the sunshine. So please do come and visit anytime you're on the south coast of England. Thank you very much.
Thank you, Saul. fantastic talk as well, and great videos, and a few questions. And what I would say actually to people listening is, Susan has taken the time and answered some of the questions fantastically, and they're on the Q&A section. So if you want to look at those, there's a lot of informative information there. And Susan, feel free to interject and ask Sol if you have any questions. I think initial two, although you mentioned some of it in the talk, and you mentioned the experiences are all out there for endonasal decompression. I'm assuming that you can, am I correct in saying you can do the endonasal decompression along with the fenestration at the same time? As in, and why, and if you have some risks from the orbital approach, I mean, why not consider that? Would you have, I guess it's new.
No, you're right. I mean,
what would you say about that?
I mean, I think as with everything in surgery, everything's based on familiarity and experience. And when you've done things lots of times, you think it's definitely the right approach. And when you've done things very few times, you persuade yourself and the whole world that it's a terrible approach. And I suspect if I'd done dozens of canal decompressions, I probably would say, actually, the view you get of the optic nerve and the ability to fenestrate a window of your own chosen size, and the likelihood of that fenestration continuing to drain because it's going into a sinus is probably much higher. But the problem is, one, there's no evidence to support that. And two, I don't feel particularly confident or comfortable. I suspect not many people in the world doing canal decompressions, whereas I increasingly feel confident doing fenestrations in the orbit. I mean, Susan's much better qualified and maybe would want to interject, but the orbit doesn't make total sense because most things get plugged with fat, but it just seems to work. Susan, any thoughts?
Yeah, I'd agree. I mean, we have a nice setup because we're a neuroscience centre here. So our skull-based surgeons do an endonasal approach when we're doing optic nerve biopsies, but we've not ventured to do optic nerve sheath fenestration this way. I think there are a number of approaches, and actually recently we've had a few more papers out with optic nerve sheath fenestration and single center experience. And I think it's going to really help inform us, because obviously you've got this medial approach, but you've also got the upper lid skin crease approach, which I put on the chat as well. And I know our Danish colleagues, I think we were talking earlier about the fact that they're doing the optic nerve sheath fenestrations, but also putting in an intracranial pressure monitor, you know, to really inform us as what happens in that ICP physiology when we do an optic nerve sheath fenestration, and why does it work so well in some people, but in other people it fails. Yeah.
I think in terms of anatomy or what makes sense, would you say, and in terms of the length of the optic nerve that you can expose, and let's say with experience, etc., what would you say would make sense more for this in terms of fenestration and decompression, or do you don't have any thoughts?
I honestly think fenestration purely because the evidence is there to support it, and probably the risks are lower. You're never going to encounter a carotid. I am aware of cases of bilateral visual loss from optic nerve sheath fenestration, which is awful. Susan's probably encountered similarly, but there have been no carotid injuries when you approach from an orbital approach, which gives one great confidence. So.
Susan, anything else to add with that?
I agree. I think your field of view, I mean, but we approach it from ophthalmologists, so it's our territory. So I would be coming from the orbital approach, you know, rather than the endonasal, but my skull-based surgeons might tell me different.
Well, the reason I'm asking, as an endoscopic surgeon, I would think, it could be something. I think it seems between a few the specialists, and I think it's the numbers which is the key, but between, you know, the anterior skull base, pituitary chaps, ENT who are interested in ophthalmology. We all have an interest in that area, but none of us probably have extreme numbers, and there may be some centers which do. But I mean, I think it would, for something like this, my kind of, I guess, theory would be, well, what makes more sense, and then you could work around that and target it. But as a standalone, you go with what you're comfortable.
There are theoretical concerns, and this is all theoretical with a canal approach, which do cause concern. The first theoretical concern is obviously you're connecting a clean space to a dirty space. So you're connecting sinus to CSF. So I'm not aware of any cases of meningitis from it, but you would have to wonder whether that's a possibility, whereas the orbit essentially remains a clean space. So The second theoretical concern, and again, theoretical, is we in glaucoma are quite familiar with the concept of a bleb forming because it's what's done for glaucoma surgery. So ophthalmologists, and the way a bleb works is you have continual filtration even though you don't have an outlet, and it just gradually diffuses. I think that is presumably what happens with a fenestration in the orbit. Whereas if you're going to do it in the canal, as elegant as it would seem and as nice as it seems to a window, you are really forming a leak rather than a bleb. And I have some anxiety about deliberately forming a CSF leak rather than something that, but that's only that's intuition rather than evidence. I don't know if that's
no, that's fair, and all useful points. I think from an infection point of view, as doing pituitary surgery again, I think it's very unlikely you really get. And obviously, if you have a persistent leak, then you need to go and with rhinorrhea, then you patch it up, as it were.
Yeah.
That brings us on to the next question. I think if we go take a step back and more broadly speaking, well, first of all, I think there's a question on the chat of we assume that you do these bilaterally for people who present to you with this problem often. Is that fair? Or you go by the?
I'm happy to be guided by Susan. I don't. If they need an neurosheath fenestration, I do one side first and see how we go.
As in the worst side first, that kind of thing.
Yeah.
And I think the literature is starting to support that. For some patients, they only need one side doing, and this is the kind of the joys of our human anatomy as to why that works. So
I mean, again, that point is quite interesting. Why, and some of your slides you showed it, why a visual field or not. Obviously, we often don't reach the why, as you say, in the wonders of our anatomy. But I guess it brings us on to one of the questions raised as well, is how related is it to the raised ICP? Obviously, it's related, but why one eye, not the other? Do you have any comments on that? I know it's a difficult question, but yeah.
I think it's like, and you touched on it with the pituitary thing, and what we talk about is in thyroid eye as well, is there are so many different things that we don't understand about what compromises visual function, what induces cell death in the optic nerve head. Some people are more vulnerable than others, must be anatomical and genetic and everything on top of that. But we don't have good biomarkers as to who are the patients that are truly, going to crash your vision at the point at which they look as though they're crashing their vision, because some of our patients recover incredibly well and some of our other patients don't recover at all. And I think that it's a huge area of work as to working, this sort of detail out. It's multifactorial.
Well, fair enough. Thank you. And Sol, if you have a patient presenting to you, and would there be, because there's questions as you would expect from neurosurgeons, well, when do we consider a fenestration, or when would you consider, for example, shunting? And I guess the question is for both of you. We'll start with Sol, and
I'm going to
give thoughts on that, apart from availability, I guess.
Yeah, no, I mean, I guess the first answer to the question is slightly, sorry for sounding slightly holier than thou, but it is such a multidisciplinary disease, and it probably needs one person to lead that patient's care, which is probably going to be the neuro-ophthalmologist, because they're going to be seeing them in clinic. But actually, I think this is where we fail in quite a lot of conditions, and thinking of orbital cellulitis is another one that touches on different specialties, neurosurgeons occasionally, ENT, ophthalmologists, sometimes pediatricians. And I think we fail with that sort of leadership and hub and spoke type model quite often in these complex diseases. And I would have, the evidence to support a fenestration over a shunt is not there. And I'm not sure one can say one is better than the other. And so some of it will be dependent on what you have available. But somewhere in many big teaching hospitals, you have all of them available. And I have to say, I don't mind as long as someone is leading the care of that patient and saying, yeah, we'll try a shunt in this one. Okay, that has or hasn't worked, and almost instructing the oculoplastic surgeon or the neurosurgeon what to do and when to do it, and in a collaborative way. I mean, I don't think you need multidisciplinary clinics, but you do need a clear multidisciplinary approach to making those decisions. And then hopefully someone, as per Susan, looking at her, is actually collecting all of that data to try and guide future decisions on which work better. And it will probably end up, I imagine 50 years from now, it'll be a more nuanced decision where we'll have a better idea of which patients will respond to a shunt, which will respond to one fenestration and which will need two, and etc. I think that's, I think we're in the dark on that, on those sorts of patient-specific, rather nuanced decisions at the moment.
So I don't have optic nerve sheath fenestration as something that I can draw my approach in very quickly. And that's been a challenge in a number of our patients that have had extreme high BMIs. And I'm thinking of patients that have BMI above 70, which has been a real challenge for neurosurgical shunting sighting. For my American colleagues that have both, they often say to me, if it's a very asymmetric papilledema, of which we actually get quite a lot, they would tend to go with an optic nerve sheath fenestration. If it's bilateral, they may go down the shunting route. The reason I like shunting is really the inline intracranial pressure monitor, and also the ability to kind of titrate, you know, with a programmable valve. And so our neurosurgical colleagues are really helpful in that. And it's one of these odd things that kind of helps later on when they get exacerbation of headache and say, well, your intracranial pressure's in this range, you know, lying down, sitting, standing, your eyes are looking good. It's definitely the headache exacerbation is migrainous-like, and let's treat it medically. So as Saul said, there's advantages and disadvantages in both. The limitation in the UK is local expertise.
I think what you've said, Susan, is a nice summary. I think if you, and as in what the Americans are doing, that would seem quite common sense to me. If either technically difficult from one side or another, obviously you're going to direct to one side or the other. And if there is asymmetric and severe loss on one side, then that would make sense to proceed with the fenestration in the first place. That would seem quite logical. But it almost is something, I think the difficulty with the condition, as we all know, is relatively low volume of it. And when it happens, it's kind of, yeah, and everybody's in a rush, and with, you know, and obviously emergency neurosurgery is generally something that's available. But the shunt is by far, as all neurosurgeons on the call will know, by far from something benign or without its complications. And there are the question about ICPs, and I think that's, as you probably will say as well, Suzanne, variable Susan, in our use. But we do have a nice development, and we've used it in Brighton, and I'm sure you have in Birmingham, where we have the tenometry, and it's a device which you can leave as an Amaya reservoir, basically, or as part of a shunt, and you can come and measure the pressure without the need to insert an ICP pressure separately. The drawback is the price of the device, but if that is available, then yeah, it can add value. The difficulty with shunting is they're often like ventricles, as you've said, and you can get patients who deteriorate despite the shunt as well. I don't know if you have anything to add on to all of that.
The only thing I was going to say is I've had that conversation with some neurosurgery managers about the cost of valves and ICP monitors. And if you bring somebody in through an A&E and you put them on a neurology ward for a couple of days for us to decide kind of what's going on, you just need one of those admissions to pay back on the NHS a value of each one of those devices. And given that the disease is a disease of the socially deprived that come in through an A&E and access services in the wrong way, we spend a lot of money on it. So I think it's like getting it right first time. It's like putting in all the gems first off to allow us to manage that patient, and almost like personalized, individualized management. And I think the ICP monitors are going to give us just great insights to the pathophysiology of the disease and ICP in general.
Well, those are all great points. And I think what we've been talking about in general for the past 10, 15 is, or certainly our discussion, is what we do when there's the visual compromise and you don't really have time to consider anything else. But if I pose the question to you, Susan, and perhaps if Saul has any input as well, is when, and some of the questions that have been asked, is when you would consider venous stenting, would you at all, and what your thoughts are on that. I can give you my opinion as well, but and also management of obesity, as we know, and I think again one of the questions of, or one of the comments have raised the fact that this is related to raised venous pressures, etc., as a pathogenesis. So what are your thoughts on that?
I'll take that comment first, because actually it was one thing I negated to say that I really wanted to underline is we can do sight-saving surgery, but we're not modifying the disease in the majority. There is a small minority of which you can break whatever the ICP cycle is, I don't know, within my practice, I have some of those that can remain without losing weight, that the shunt works, and even if it blocks, continues to work. But for the majority of these patients, weight management is critically important. We did a very low calorie diet randomized control trial here in Birmingham. 15% body weight loss showed reduction of ICP, reduction of headache, and resolution of papilledema. We've completed the IIH weight trial. We're very much hoping that it's in review at the minute, a couple of reviews, and we very much hope that will be published at least by May this year, that shows bariatric surgery for people with chronic IIH is incredibly helpful at reducing ICP and making patients feel better. So modification of the disease, and the disease itself we can talk about, to the stenting modality for sight saving. Yes, my American colleagues in certain centres feel that there is a role for stenting. There's definitely a role for stenting in sight-saving cases. The problem is the literature has a myriad of case series that don't define headache outcomes and don't define ophthalmic outcomes. And then it makes it really difficult for us to work out the complications versus the benefit in a heterogeneous kind of group. So more work's needed there, and we really hope that there'll be a randomized trial in the UK to hope answer that question. But again, these things take time. It'll be 7 years before that reports.
That's all very helpful. And vena stenting, do you have any role for it in Birmingham? Do you in your practice?
So there are a few patients that we've had that have not fit the same typical criteria that we would say for an IIH person. So I'm talking about atypical IIH and somebody that has a BMI of a normal range, where we've been able to perform venous imaging that shows stenosis, and had discussions with the neuroradiologists as to putting a stent in. We've not gone as far as performing procedure when they've sat down with the neuroradiologist. And in some of those, they've settled nicely with Diamox and other treatments. But I know in other centres in the UK and around the world, they have a much greater experience of stenting. I think some of the nicest literature is coming out of New York with Mark Dinkin, looking at a very specific IIH specific stent. So instead of using a hepatic stent or a cardiac stent or something like that, and that's going through phase 2 trials. So, I think this is an open book. I think we've got to be cautious that we don't have good trial evidence, and it is going to come. But we very much, in Birmingham, have the equipoise to say that if somebody says that this is the procedure to do at this point for these patients, we would certainly adopt it.
Well, I think it's what you're touching upon is quite nuanced for individual patients often, and that's often the case when you have multimodal treatments. And there's a question on the chat of what's preferable, a VP shunt or an LP shunt. I think I'll take that as something to ask an ophthalmologist, that question. And I would say, for me, generally speaking, it would be a VP shunt, but obviously depending on the size of the ventricles. And you tend to, the entry point tends to be a bit more medial than usual because you're trying to get it right at the foramen of Monroe. So yeah, that's what I would do. There is a role for an LP shunt if you can't put a VP shunt in, is my practice. But there is a risk that they might end up developing a sort of Chiari or a secondary Chiari to that. But there are some centers who depend more on LP shunt. So and I guess the added advantage of the VP, as we've just said, is inserting a telemetry device at the same time.
I think we're the same. I mean, we like VP shunts because of the devices that you can put in tandem with them. We would probably go towards an LP if somebody in the UK, there's certain restrictions on driving a passenger vehicle. So we've had some people that really can't live without driving for 6 months, albeit they're at sight-threatening changes. So again, our preference would be that as well. But there's lots of evidence both ways, isn't there, as to the success of one or the other.
And again, as Saul has mentioned, there's probably a bit of practice, what you've trained on, etc. There's a lot of nuances in these things that we didn't speak much because none of us are neurologists, I guess, and look after these patients from a medical management point of view. But I think Suzanne, you might be able to answer this, and or maybe from the literature or your own view of the patient, your patients, and how many do you think are managed by acetazolamide alone or medical management alone? Do you have a rough idea of percentage of these patients?
Well, we do actually, because actually in the UK, we're not good takers of acetazolamide. Generally, our patients hate it. So about 40% of our patients we put on acetazolamide will come off it at a very low dose. We can't escalate to the doses that the Americans do, so they tend to get their patients up to nearly 4 grams. That makes you really sick, nauseous, lethargic, and there are many other risks with that. In our practice here, we discuss it with our patients because the IIHTT, again, interpreting trials is really tricky. It was used in mild visual loss along with a weight management intervention. And the patients that had diamox and weight management intervention did lose more weight. And they did a mediation process to say it was the diamox. So our belief is management first off is weight management. There's some patients whom we've had raw medical monitors in where we've challenged with diamox and topiramate and spironolactone and frusemide, and some of that data will probably come out later end of this year. And our feeling is from that data is some people respond well to acetazolamide and some people don't. So it's getting back to this precision medicine. There's certain things that are upregulated in the choroid plexus, and some people are going to be more sensitive to diamox than others. So we offer it to all our patients because we feel that's important for them to understand the medical literature, but not all our patients either wish to go on it or wish to take it.
Again, some fantastic information there. And again, you've shown the role of telemetry and monitoring and how that can help probably inform us in the future of the role of all of these modalities. For me, I think this has been a fantastic discussion overall. I personally learned a lot. It's great seeing both of you. And I don't know if you have any closing remarks, or there's no, I think we've covered most of the questions. So in summary, for me, it's a complex disease. Often when we're involved, it comes to the stage of urgency, but it's good to have all these options available. And it's, I think, as you mentioned in your presentation, the NNAP paper, the consensus sort of questionnaire, I think summarizes a lot of what we've been talking about and probably similar views to any of the attendees who want to kind of look at that. But if you have any closing remarks, Susan and Sol?
No, I think it's a really exciting disease, and I think, as we've all said, we've all got to work together because it's really tricky, and the patients, you know, they're in a lot of difficulty, and we can do an awful lot to help them.
Thank you, Susan. Sol, any closing remarks to neurosurgeons?
No, I echo that, and it's a pleasure as always to work with neurosurgeons and to present with neurosurgeons and neurologists, neuro-ophthalmologists. Thank you very much.
Thank you so much, Sol, and thank you, EANS, and thank you, Mansour, for inviting us. And I think we'll say goodbye. Thank you.
Brilliant. Thanks very much.
Thank you.